This video is part of a teaching series created for the University of Wisconsin-Madison School of Veterinary Medicine, intended to summarize some of the general principles used when assessing generalized cardiac size in canine and feline patients using thoracic radiography. When evaluating cardiac size on thoracic radiographs, appropriate positioning is critical. Rotation, obliquity, or poor inspiration can compromise diagnostic accuracy and result in misinterpretation. On the lateral view, a normal canine heart typically spans 2.5 to 3.5 intercostal spaces in width, as delineated by the white line on the right image. Also, on the lateral view, assess the relationship between the thoracic trachea and spine. In most dogs, there should be divergence of the thoracic trachea and spine in the caudal thorax, as noted by the orange lines in the right image. Parallel alignment oftentimes indicates a vertically enlarged or tall heart, which may be caused by either left or right-sided cardiomegaly. Some exceptions to this rule include some small breed dogs with a naturally reduced thoracic height, like Dachshunds, demonstrated in the left image, in whom this is a normal variant. Note the decreased divergence of the thoracic spine from the trachea in the Dachshund, noted by the blue lines in the left image, compared to more normal divergence seen in a standard poodle, noted by the orange lines in the right image. In ventrodorsal or dorsoventral views of a canine patient, the widest aspect of the cardiac silhouette, denoted by the yellow line, should occupy less than 2/3 of the thoracic width at the same level, denoted by the pink line. When evaluating cardiac size in feline thoracic radiographs, on the lateral view, the normal feline heart typically spans approximately 2 to 2.5 intercostal spaces wide, as denoted by the light blue line. The cardiac silhouette should be slightly elongated, with tapering height and width at its apex. Additionally, on the lateral projection, there is usually an intercostal space between the cardiac apex and the diaphragmatic capula, as denoted by the orange arrow. The cardiac apex in direct contact with the diaphragm over a broad surface or being rounded in shape may suggest cardiomegaly. Up the ventrodorsal or dorsoventral view, the feline heart is normally narrow and elongated, with the apex positioned slightly to the left of midline. The width of the cardiac silhouette at its widest point should measure less than 65% of the thoracic width. Vertebral heart scores are another objective method for evaluation of canine and feline cardiac sizes. On lateral radiographs, this is performed by a long-axis measurement from the ventral border of the carina, which is where the trachea bifurcates, to the most distal point on the cardiac apex. An additional short-axis measurement is performed perpendicular to the long-axis measurement at the widest aspect of the cardiac silhouette. These two measurements are individually superimposed over the thoracic vertebrae, starting at the cranial margin of the T4 vertebral end plate. The number of vertebrae covered by each line is counted to the nearest 0.1 vertebrae, and the long and short axis values are added to determine the vertebral heart score. The normal vertebral heart score on lateral views has been reported in a mixed population of 100 dogs as being less than or equal to 10.7 V or vertebrae, with the lower range of normal distribution reported as 8.5 V. Cats typically have a vertebral heart score on less than 8 V. Evaluators should be wary of utilizing a single measurement reference range as the sole evidence of cardiomegaly, and consistent technique breed familiarity, and attention to radiographic landmarks are essential for accurate assessment of canine and feline cardiac signs. Some age-associated variants of the feline cardiac silhouette include a more horizontal position of the feline cardiac silhouette in geriatric patients, as noted in the left image. Additionally, a redundant, elongated ascending aortic arch with extension away from the cardiac silhouette may cause the ascending aorta to have a more tortuous, displaced position, as denoted by the pink shaded region. Pitfalls for misinterpretation may include mistaking increased pericardial fat for cardiomegaly. This occurs most frequently in obese patients and should be differentiated by identifying fat veracity outlined by the white arrows, which is differentiated from the normal soft tissue opaque cardiac silhouette. As mentioned, this occurs most frequently in obese patients who often have increased subcutaneous, mediastinal, and falciform fat, as noted by the pink double-headed arrows. Other pericardial diseases may also result in an increased size of the cardiac silhouette, including pericardial effusion, peritoneal pericardial diaphragmatic hernias, or pericardial masses. This image demonstrates generalized enlargement of the cardiac silhouette in a canine patient secondary to hemorrhagic pericardial effusion with secondary metastatic pulmonary nodules. In summary, evaluation of the general size of the cardiac silhouette may be facilitated by evaluating how many intercostal spaces the cardiac silhouette spans in the lateral view, evaluation of the height of the cardiac silhouette, which contributes to the relationship between the thoracic trachea and spine, and evaluation of the cardiac width to thoracic width ratio. Other more objective measurements, such as vertebral heart scores, may be utilized to support a diagnosis of cardiomegaly, though evaluators should be wary of using a single measurement as justification for diagnosing cardiomegaly.